Today we're talking about hemostasis, the body's system for stopping bleeding. This is one of those topics that gets taught with a lot of memorized steps and factor numbers, and students often come away confused. We're going to take a completely different approach. We'll treat hemostasis as a logical sequence, a three-step system, and then show you how bleeding disorders map onto that system. By the end, when you see a patient that's bleeding abnormally, you'll know exactly which part of the system to investigate. Hemostasis is a really four-stage process. The vessel itself responds first by contracting, then platelets rush to the injury site and form a quick but temporary plug. Then the coagulation cascade, a series of protein activations, lays down a stable fibrin mesh that anchors the clot in place. And eventually, once the vessel heals, fibrinolysis breaks the clot down so blood flow can resume. Here's the key insight. A patient who's bleeding abnormally has a failure somewhere in this system. Your job is to figure out which stage is affected, because the clinical signs and the tests you run will be completely different depending on where the problem is. Primary hemostasis is all about platelets. When a vessel wall is injured, the collagen underneath the endothelium is exposed. Von Willebrand factor, a big adhesive protein that normally circulates in the blood, acts as a bridge, grabbing onto collagen with one arm and platelets with the other. Platelets stick, activate, and recruit more platelets, forming the primary platelet plug. This plug is fast. It forms in seconds, but it's fragile. It'll hold for a while, but without the fibrin clot to reinforce it, it can fall apart. The classic clinical signs of primary hemostasis failure are petechia, those tiny pinpoint hemorrhages you see on the gums or belly skin, and mucosal bleeding. This is your platelet problem sign. Big body cavity bleeds come from secondary hemostasis failure. Different story. To evaluate primary hemostasis, start with the platelet count, but always confirm it with a blood smear to rule out clumping, as we covered in Mini Talk 1. Then consider a buccal mucosal bleeding time, a small standardized incision on the inner cheek, and you time how long it takes to stop bleeding. This measures actual platelet function in the living animal. A normal platelet count with a prolonged BMBT means the platelets are there, but they're not working right. Think von Willebrand disease or NSAIDs like aspirin that block platelet activation. Doberman pinschers, for example, have a very high prevalence of von Willebrand's disease, and it's absolutely worth testing before any elective surgery. Secondary hemostasis is the coagulation cascade, and I know the word cascade makes people nervous, but here's all you really need to understand. There are two entry points, the extrinsic pathway triggered by tissue damage and the intrinsic pathway triggered by contact with exposed collagen. And they both funnel into a common pathway that produces thrombin, which converts fibrinogen into fibrin. Fibrin forms the mesh that holds the clot together permanently. The two clotting tests we run, PT and aPTT, each test a different part of this cascade. PT tests the extrinsic and common pathway. aPTT tests the intrinsic and common pathway. If only one is prolonged, you know which part of the cascade is affected. If both are prolonged, the problem is in the common pathway, or there's a widespread clotting failure. Here's where PT and aPTT become incredibly powerful clinical tools. If only the PT is prolonged, the problem is in the extrinsic pathway. Factor VII is the most common culprit, especially early rodenticide toxicity, because factor VII has the shortest half-life of all the clotting factors. If only the aPTT is prolonged, look to the intrinsic pathway. Classic examples are hemophilia A and B, which are sex-linked factor deficiencies. If both PT and aPTT are prolonged, the common pathway is involved, or there's widespread coagulation failure. That combination, both prolonged in a sick animal with low platelets and bleeding from multiple sites, points you strongly toward DIC, which we'll cover in a moment. Fibrinolysis is the cleanup phase. Once the vessel is healed, the clot needs to go away. The enzyme plasmin breaks down the fibrin mesh, and those breakdown products, D-dimers, are released into circulation. So a D-dimer test tells you that somewhere in the body, clot formation and clot breakdown are both actively happening. In a critically ill patient, elevated D-dimers combined with low platelets, prolonged PT and aPTT, and low fibrinogen point strongly toward DIC. But D-dimers are not specific. They'll be elevated after any surgery, with a big hematoma, or with a pulmonary thromboembolism too. They're a sensitive alarm, not a specific diagnosis. DIC is one of the most serious clinical syndromes you'll encounter. It's not a primary disease. It's what happens when a massive trigger, sepsis, pancreatitis, severe hemolysis, causes widespread, uncontrolled clotting activation throughout the body. Ironically, the body clots so much that it runs out of platelets and clotting factors, and then it can't clot when it needs to. So you end up with a patient who is simultaneously forming tiny clots in their capillaries and bleeding uncontrollably from wounds and IV catheter sites. The lab picture tells the story. Everything is abnormal. Low platelets, prolonged PT and aPTT, high D-dimers, low fibrinogen. Treatment is directed at the underlying cause. Fix the trigger and support the patient while the clotting system recovers. Here's the systematic approach to any bleeding patient. Start with the clinical signs. They tell you which stage to investigate first. Petechia and mucosal bleeding point to platelets. Muscle hematomas and body cavity bleeding point to coagulation factors. Then run the tests in order: platelet count, PT and aPTT, D-dimers, and fibrinogen. The pattern of abnormalities tells you what's failing. If all the numbers are going the wrong way, think DIC and work urgently on finding the trigger. The framework makes a complicated topic manageable because you're following the physiology. The most important takeaway is the framework. Primary hemostasis fails, leads to mucosal bleeds and petechia. Secondary hemostasis fails, points to deep, large bleeds. And DIC is both, happening at once in a very sick animal. The tests, platelet count, PT, aPTT, D-dimers, are each a window into a specific part of the system. When you learn to read those windows together, you can localize any hemostatic failure with confidence. Question 1. Petechia, very low platelets, and everything else is normal, including the coagulation tests. What part of the hemostatic system is failing here, and what are you thinking for differentials? This is a primary hemostasis failure, specifically severe thrombocytopenia. The fact that PT and aPTT are completely normal rules out a coagulation factor problem. So we focus on the platelet side. In a dog this young with this severe a drop, immune-mediated thrombocytopenia, IMT, is the leading differential. The immune system is producing antibodies that target and destroy platelets. Tick-borne diseases like Ehrlichia and Anaplasma are also very common causes of thrombocytopenia and can be severe. Always ask about tick exposure. and neoplasia, especially splenic masses, can consume or displace platelet production. An abdominal ultrasound is an important early step in these patients. 2. Normal platelets, but both PT and aPTT are dramatically prolonged. Large hematomas from minor trauma, that's secondary hemostasis failure. Based on the history and this age and signalment, young dog, possible ingestion outside, what's the top toxin on your list? And why is PT the first test to go abnormal? Anticoagulant rodenticide, most commonly a second-generation product like Brodifacoum, is the textbook cause of this picture in a young dog with outdoor access. These rodenticides block the enzyme that recycles vitamin K. Without functional vitamin K, the liver can't produce active clotting factors 2, 7, 9, and 10. The animal bleeds, but not immediately because it takes a day or two to deplete the existing factor stores. Factor 7 has the shortest half-life of all the affected factors, about 6 hours, so the PT, which tests the extrinsic pathway where factor 7 lives, will go abnormal first. By the time the animal is bleeding clinically, all the vitamin K dependent factors are depleted, and both PT and aPTT are markedly prolonged. Treatment is vitamin K1, and it needs to continue for 4 to 6 weeks with second generation products because they persist in the body for a very long time. Question 3. Every single clotting test is going the wrong direction. Low platelets, prolonged PT and aPTT, high D dimers, very low fibrinogen. And the dog is bleeding from everywhere. What is happening here, and what's the first treatment priority? This is DIC, and it's one of the most challenging clinical situations you'll face. The systemic infection from the ruptured intestine has triggered massive, uncontrolled coagulation throughout the body. The body is forming clots everywhere, in small vessels, damaging organs, while simultaneously running out of every component it needs to clot. So paradoxically, the dog is also bleeding from everywhere. The most critical concept in DIC management is this: you cannot successfully treat DIC without addressing the underlying trigger. Fresh frozen plasma will transiently replace clotting factors, but they'll be consumed again immediately if the infection isn't controlled. This dog needs surgery, antibiotics, and aggressive supportive care. And even then, the prognosis is guarded. DIC is treated as a syndrome, not a disease.